Hello, everybody. Welcome back to the Incubator and Neonatology Review Podcast. We are here with Rooney Toms going over cardiology. Rooney, how are you?
No, I'm doing great today. Thanks.
We're going back to some cardiac physiology today. You're going to talk to us about the Frank-Starling curve. Is that right?
Yes. We're going to talk a little bit about, again, as a board review concept, right?
Fair
so
enough.
Very quickly, will they throw up one of these curves?
Yeah.
And we've all gone through these curves in physiology class, but it tends to be a little while back. And then they, and again, you don't have a whole lot of time to answer these questions. So then it's nice to have thought through the curves before the actual exam. And then if things pop up as part of the use of inotropes and such.
Yeah, how does that change?
How does that change?
You got it.
So very quickly, this is your classic kind of format. You have your left ventricle pressure here and your left ventricular volume at the bottom. So imagine if you have basically a heart hanging on a string and you start filling it with water, okay? In an experimental situation. So you start filling it with water. As you're filling it up, your volume increases, okay? So here you're increasing your volume. Pressure is not really going up. I apologize. And these little bumps here doesn't mean anything. This is just me.
Hand drawn.
Yeah.
This is a Rooney original.
The Rooney original for sure.
But for the people who are listening, because we are also on YouTube, right? So you're starting from the bottom left corner of the curve, and you're saying we're increasing. We're just we're filling the ventricle, and so there's very little change. And then you're describing that as we get to the lower right corner, there's like a little bit of an increase as the pressure, as the ventricle gets pressurized with fluid, basically.
Yeah. So you start filling, you fill it first, and then all of a sudden you start filling. But as you fill it more, you start stretching it. Okay?
Exactly. Almost like a water balloon when you're playing as a kid.
I think that's how I imagine it too. So then obviously the pressure is going to start increasing, right? And then it starts increasing up here. So this is basically at the end of your filling phase, right? So this is at the end of your diastole, right? And for the record, if you have a patient with decreased function, cardiomyopathy or whatever, the primary marker for decreased function is your end diastolic pressure. Yeah. Okay. So if you have a suspicion for someone with a cardiomyopathy, you take them to the cath lab. You throw in the catheter and you say, "Oh my gosh, left ventricular end diastolic pressure is 20." You know this is a bad case of heart failure, right? So, so you don't want this to be too high, obviously, but this is your end diastolic pressure. Okay, and then here you have a very sudden increase in your pressure. So you're kind of basically going straight up, right? So this is when your left ventricle starts contracting.
So that's when all the valves are closed. You have your mitral valve is closed, your aortic valve is closed, and now the ventricle is going to start contracting, but the blood has really nowhere to go.
Yeah, the blood is still standing inside its left ventricle, and all the walls filled with muscle is contracting.
And that's why it's called isovolumetric contraction, because the volume is not really it's not going to change at all. Correct. But the pressure goes really high.
Exactly. And that's where you see this on this curve. There's no change in the volume, right? The volume stays exactly the same, but the pressure just shoots up.
Yeah.
And then you get to the top of this kind of pressure increase. This is when the aortic valve opens. Yeah. Okay. So now the pressure is great enough that it oversees the pressure in the aorta. Yeah. So the aortic valve opens and you start having an injection. Yeah. Okay. So systole starts here, right? And
at
then,
the bottom right corner.
Yeah. And then you have your increase in pressure, no change in volume. Bang, your aorta opens here. Yeah. And then you start injecting your blood and you start losing the volume, right? As it comes down. And then the pressure slowly starts coming down. It actually does curve like this. It doesn't stop immediately, but does decrease a little bit. And then as you've ejected a large amount of volume from your left ventricle, most of it, then all of a sudden the aorta closes and your LV pressure drops.
Yeah. Exactly. That makes sense.
Yeah. And then it starts over again. All right. So this is basically the basis for some of these Frank-Starling rules and how can you see this at the bedside? Okay. And I find this very very helpful because a lot of people just ask me, hey, what inotrope do you like best? And it's like, no, it's not about what I like best. It's what about what does the patient need, right? And what's necessary in that situation. And that's why describing this through these curves can be very, very helpful. Okay, so here again, pressure and volume, and these are classic board review questions, right? So they will ask you what's the difference between A and B and C, and C and D, that kind of stuff. So here, for example, A is normal, where you kind of increase your volume and you contract and you eject this amount of blood, okay, from 50 to 20, say, all right? And then you've done something. And in this case, you've increased your preload, okay? You recruited, you've given more volume, okay? You've given a volume bolus, okay? In this case, your filling is from A to B. So that means that you're actually filling more volume, right? You're filling the distance from A to B as you're filling the heart more, stretching more. So the pressure and diastolic pressure is slightly higher. But at the same time, when you actually contract and you eject, you're ejecting this much more blood, right? So you're almost up at 65. So you almost increase it from 45 to 65 additional kind of volume. And then further, you go from you can give even more preload, right? Give even more of a volume. So then you can actually go from B to C. Okay. And then you have actually added even more. So, but as a side effect, what has happened is that you have increased your end diastolic pressure. Okay. And by doing this, you potentially making it so that you can start having kind of heart failure type symptoms. And in our preemie population, the first one we would think of is kind of more pulmonary edema aspects. Okay. Then from C to D, you have a very limited increased volume of ejection. Okay. So you're not actually increasing your stroke volume all that much, right? So your bang for your buck is greatest from A to B, less from B to C, and very little from C to D, right? But the side effects of going from C to D is quite significant because now you're actually starting to really climb up there on your end diastolic pressure. So that means all the discussions kind of in conferences and such, like how much volume should we give? Okay, depends on the situation, depends on the clinical scenario. Is the baby hypovolemic, and what's your assessment of the hypovolemia? Does the baby have sepsis and such, right? But no, at some point you will reach point C and D. So to continue all night long to give volume boluses is probably not in the baby's best interest, right?
Okay. Heard it here first.
All right. So then the next one is positive Lucidropy. Okay, that's actually one of my favorite ones because some people actually spend their entire life studying diastole, and diastole is actually almost more interesting than this systole, because diastole is how do you actually relax the ventricle. Okay, and that's the Lucidropy. Okay, so the lucitropic effects is how you can influence the relaxation of the ventricle. Okay, so this is a classic situation. Again, same curve, pressure and volume, and you're going from state A to state B. In A, again, you come up here and you fill the ventricle and you eject, and this is your stroke volume right here. Okay. And then, but if you increase your lucitropy, and the classic poster child for lucitropic medication is milrinone, of course. Okay, then you help the ventricle as you're kind of filling it with water. You helping it be able to absorb that extra water without really increasing end diastolic pressure.
You're helping it to accommodate all that larger volume.
Yeah, it's almost like making it stretcher. So if you the water balloon scenario, right? If you fill it once and it's kind of stops right here, but then you stretch it and do it, you make it so that it can
you're increasing the compliance.
Exactly. Yeah, exactly. So that's when you go from point A to point B. You see that this curve can accommodate much more volume. So in this case, you actually almost doubled the stroke volume, right? So you go from here, you're not increasing any pressure. You're not putting any more strain on the heart. But you're just basically allowing it to fill more, and it uses the same amount of pressure to eject almost double the amount of volume. So cool. Yeah. So that's a very helpful way of thinking, does this baby have diastolic dysfunction? Diastolic dysfunction is not necessarily easy to diagnose, but again, if the heart kind of looks as though it's beating fast, it's you have tachycardia, it's not filling very well, and all that kind of stuff, and depending on the pathogenesis of what's going on, you can say, hey, this baby probably would benefit from some positive Lucidropy because it has some end diastolic dysfunction. Is kind of what we like to call it. And then in other ways, you can increase contractility, and those are your classic kind of dopamine and dobutamine and such. Dobutamine kind of also releases your afterload. Maybe has some degree of lucitropic effect, and low dose epinephrine can have some lucitropic effect and afterload reduction. But here, increase your contractility. So how does that really happen? So let's look at the first one. So this is curve number A. So you're kind of going up here relatively high on the curve, and with your contractility, you're not really squeezing out that much volume. So you're actually just going to here and down. So your volume is really just from the 65 to 45 range. Okay. By increasing your kind of your muscle tone, your muscle kick in many ways, you can go from A to B, you're basically doubling your volume here by increasing your contractility. Okay, so it's just a harder push, right? And from here to even C, you can actually almost triple it with your contractility. So therefore, you can see how maybe some of these combinations can be helpful in patients where you might increase some volume, right? As preload, you may actually help some degree of diastolic dysfunction, and might also want to help with the contractility to some degree. So you see how they all work in favor of the heart, but in different
two phases. There's really ways. 2 phases on which you can have very different impacts.
Yes, exactly. And then the last one, I believe, is afterload reduction. Okay, that basically, remember when we talked about going on positive pressure ventilation, and that practically reduces your afterload. There are different ways in which you can reduce afterload. Basically, what that really means is lowering your systemic vascular resistance, which practically also probably means lower your blood pressure to some degree, right? So then you go again, left ventricular pressures, volume here, you go up. So let's look at course number A. So you go from A to B. So you come up here and you eject. You're actually using a lot of pressure, right? And then you eject down to here.
Yeah, that's our natural curve, which is the heart working super hard against this high afterload.
Yeah, exactly. This is what, if you have high blood pressure.
Yeah, exactly.
This is what's going on.
Yeah.
But if you then reduce your afterload, and look, you're going up on the B curve, which is
so your diastole is not going to be changed tremendously.
No, diastole is the same.
Exactly.
Right? Yeah, exactly. And then you go up here, but your pressure that you have to generate in order to overcome exactly, right. And then is less. So then because the pressure is less, you also are able to have a larger stroke volume and larger volume that comes out of the ventricle, and therefore you have basically more volume that reaches the body, right?
That makes sense.
And here in more extreme example, C coming up here, high pressure, very little output comes down, and then going from C to D, which
lots of residual volume there.
Exactly. And here you kind of almost double your stroke volume, and it comes down here. Yeah. So I feel as though we maybe see this classically in a BPD patient that has had hypertension, right? And might get sick for different reasons. and reducing the afterload in a patient like that could kind of help with the stroke volume. And I think that kind of wraps up the Frank Starling discussion.
All right. Thank you, Rennie.
Yeah, thanks.
See you tomorrow.
Mm-hmm. I think that was the last one.